this study is a patient who was a non-insulin dependent diabetic or a type 2 diabetic, and you see that the uptake by the heart is very patchy, and this is a typical appearance for a patient with non-insulin dependent diabetes. FDG PET is commonly used in the diagnosis of cardiac sarcoidosis. The other modality is cardiac MR. And with cardiac MR, you see delayed gadolinium enhancement or late gadolinium enhancement. And in that setting, the sensitivity is about 80%, then the negative predictive value is about 80%. But there are challenges with MR, and one is ischemic disease. You can get subendocardial late gadolinium enhancement. Fibrosis from prior myocarditis or idiopathic cardiomyopathy can also complicate matters and appear like active sarcoidosis. And focal hypertrophy of the heart, especially apically, can cause increased uptake as well. The protocol for scanning cardiac sarcoidosis is specific. It's necessary to completely suppress the insulin effect. So these patients are placed basically on a meat and egg diet for 2 days prior to the procedure, and then they're fasted for 12 hours. Sometimes unfractionated heparin is used prior to injection to further reduce uptake of glucose by the heart. The sensitivity is slightly better than MR at about 90%. The specificity is similar, about 78%. But it has an advantage of following active disease over time. Doing a whole body scan as well and identifying the presence of systemic sarcoidosis increases the likelihood of cardiac sarcoidosis to about 50%. Here is a patient with a good correlation between the cardiac MR showing septal and basilar delayed gadolinium enhancement, also some in the right ventricular apex. And if you notice here on the FDG PET, this is the same pattern that you see with the cardiac MR. In addition to that, you see evidence of splenic involvement. The spleen is diffusely hypermetabolic, and there are multiple large lymph nodes within the mediastinum. This pattern of uptake, where you see very symmetric balanced distribution within the mediastinal and hilar lymph nodes, is very typical for cardiac sarcoidosis. This pattern where you see upper lobe activity is more typical for either tuberculosis or progressive massive fibrosis due to silicosis or other inflammatory lesions as well. Patients will present with concurrent sarcoidosis as well as cancer. And in those patients, the treatment for cancer does not typically alter the activity that is due to sarcoidosis or other granulomatous disease. This is an example of a patient who actually had a diffuse large B-cell lymphoma of the proximal tibia. With treatment, he got progressively better. But if you'll notice, the pattern of uptake, again, kind of a symmetric balanced distribution. Upper lobe nodules actually progressed over time. And that corresponded, I don't know if you can see this well enough, there were an increased number of nodules within the lungs. So progression of sarcoidosis, but improvement of PET. This patient also had a bony lesion here that actually was thought to most likely represent sarcoidosis. This is a patient who had diffuse lymphoma. This patient is an AIDS patient, HIV-positive AIDS patient. With treatment, the pattern changed. Many of these nodal sites disappeared, but there was a lot of persistent disease. These were, multiple lesions were biopsied. They were all negative. This is consistent with lymphadenopathy associated with HIV. And it can sometimes be difficult in a patient with HIV to know whether their lymphoma is improving or not because of the nodal disease. The nodal disease has been shown to correlate with the viral burden in these patients. For endocarditis, abscess, or infection, we like to put the patients on the same ketogenic diet as sarcoidosis if possible. These patients are often more sick and it's more difficult to put them on a severe diet. We do a high-resolution cardiac PET-CT, ideally with late venous phase contrast, so you can delineate the structures within the heart. It's also important in these patients with suspected endocarditis to do a whole-body scan if you want to identify seeding to or from a distant source. This is an example of a patient. This patient was a tetralogy of Fallot. He was an adult patient but had a congenital heart disease, and you see this circular area of uptake. This was a pulmonary outflow graft in this patient that became infected. I think it's interesting if you look at these two CT scans. This is an earlier CT in which you see the nice, well-defined margins of the outflow graft, but notice here, which corresponded to the same interval, you can see that there are little out pouches. I don't know if you can see those well, little out pouches, so pseudoaneurysms of the conduit, the pulmonary conduit. This is another patient with intense uptake around the aortic valve. If you notice on ultrasound, there's actually a fluid collection around the aortic valve here. And this is a patient who had a perivalvular abscess. We are not as sensitive at picking up vegetations within the heart. Sometimes you can't see those, but for perivalvular abscesses, PET is quite sensitive. This is another patient who had uptake, sort of patchy uptake in the pericardium, and also had intensive multifocal areas within the lungs with bilateral pleural effusions. This is a patient with rheumatoid arthritis and had rheumatoid pericarditis. This was not infection. This is a different patient, also with rheumatoid arthritis and rheumatoid lung, showing you the extensive multi-articular distribution of increased metabolic activity and the diffuse lung opacity. This is a patient who had polymyalgia rheumatica on the right. And if you'll notice, the pattern of uptake really isn't in the joint space as much as it is in the soft tissues around the joints. Notice here around the hips. This patient had a C-reactive protein that was very high at 57. Following treatment with steroids, there was a significant improvement in the disease. So PET is not usually indicated in this entity, but it is helpful. Vascular uptake on FDG PET can be indicative of underlying disease. This is a normal patient. Usually you don't see much uptake in the wall of the vessels, the large vessels. This is a patient with a large vessel vasculitis, where you see diffuse uptake in the wall of the aorta and also in the subclavian arteries. This patient had atherosclerosis. Atherosclerotic disease tends to be much more patchy in its distribution. This is another patient with a large vessel vasculitis, showing the extent of activity within the medium and large vessels. This is yet another patient. In this patient, you have just intense activity in the subclavian arteries. Notice here how hot these are going down into the arms, and also in the legs. You can't see this very well, but this is the SMA showing intense uptake in the wall. So inflammatory disease of the vascular wall is not the only thing that will cause uptake in vessels. Acute deep venous thrombosis can also be metabolically active. If you look at clot, acute clot under the microscope, there are a lot of neutrophils in it, so the clot is hot. And this is a patient at one week after development of deep venous thrombosis, extensive uptake within the leg. And actually, there was a follow-up scan at 3 weeks and at 6 weeks showing resolution of the increased metabolic activity over time. This patient was part of a clinical study that we did related to deep venous thrombosis. This is a patient with uptake within a soft plaque. These are inflammatory and should be differentiated from an infection or clot, but this is a patient with a soft plaque. This is a patient with a dialysis graft that was infected, diffuse metabolic activity. The lungs, there were multiple hypermetabolic foci consistent with septic emboli, and this patient had a large empyema of the pleura. This is a patient who had a bypass graft for atherosclerotic disease, and periodically the groin wound would break open and would ooze pus. That's not a good sign generally. They wanted to know what the extent of infection was. They suspected infection, and if you'll notice here, there's just intense uptake, both of the common iliacs here as well as the aorta. And the CT corresponds to a small amount of fluid around this lesion. So this is an infected aortobifemoral graft. You have to be careful though, because especially with open grafts that are placed open, endografts are not as big of a problem, but the open grafts tend to develop host-reactive change, which can cause increased uptake along the graft, and that can persist for about a year afterwards. So you have to be a little bit careful. Uptake in the graft is non-specific if it's relatively acute. Host reaction to foreign material also occurs in other situations. This is an example of a patient who had a ligamentous reconstruction of the knee, and this material showed reactive change around it. This is very common with ligamentous reconstructions and does not mean that there's infection. This is a patient who had breast cancer and had talc pleurodesis, and you can see increased uptake where the talc is. This is also a host reactive change. The talc incites a very strong inflammatory reaction, which is one of the ways that it fibroses the pleura and is effective. So that's a normal finding, does not necessarily mean recurrent tumor within the pleura. You've seen cases like this also shown by Ahmed and Dr. Covington, but this is a patient with bilateral breast prosthesis. There's increased uptake in several lymph nodes, and the suggestion was, well, is this a lymphoma, recurrent breast cancer, or what? But in doing there are two ways of dealing with this with other imaging. One is with ultrasound, which shows this sort of snowstorm pattern that is very typical for silicone granulomatosis. And the other thing is to do a silicone-specific sequence on MRI, which shows increased uptake in the lymph nodes. So this was not tumor. This was a leaky prosthesis with silicone granulomatosis. This is a patient with pneumonia and a lung abscess. Often the interior of the abscess is hypometabolic. There's a small focus of air here, which is also a clue that this is a lung abscess. This is another patient who had a history of chronic actinomycosis of the lungs and developed worsening symptoms. Her CT scan was unchanged from multiple prior CT scans, but on PET you can see that there are focal areas of increased activity within these areas of opacity that suggests that there is an active component to infection. This is another patient. This was actually a patient with Hodgkin lymphoma who was treated and then developed pulmonary symptoms. Her CT scan demonstrated multiple mass-like areas of consolidation with surrounding ground glass opacity. The differential was pulmonary aspergillosis in an immunocompromised patient versus recurrent lymphoma. This actually was recurrent Hodgkin lymphoma, but the distinction between those two cannot be easily made with PET. This is a patient who had an esophageal cancer and was treated with radiation, chemotherapy and radiation, or CRT. This is the follow-up scan here, which demonstrates diffuse increased uptake in the right lung with kind of a geographic margin, as well as kind of diffuse uptake in the esophagus. This is post-radiation pneumonitis due to the radiation. Generally, this will go away by about 3 months, but the activity does not necessarily go away when you have cicatricial atelectasis resulting from radiation, because there are multiple dilated airways, bronchiectasis and bronchiolectasis within this, and those are chronically inflamed. And so this appearance is typical of radiation fibrosis, cicatricial atelectasis with chronic inflammation, and it can persist indefinitely. This is a patient who had breast cancer. She had bilateral mastectomies and tram flap reconstruction of the breasts. The superior margin of the breast showed increased uptake on the PET scan. And these are axial views, again showing increased uptake within this area of opacity along the superior aspect where the tram flap was attached, and also in the abdomen at the origin. This is all fat necrosis, and fat necrosis shows increased activity on PET. It is not something that resolves with time. It can persist. These are 3 separate patients. This is one I showed earlier. That's a patient who was on, who had taken either carbohydrates or could have taken insulin prior to being injected with diffuse skeletal muscle uptake. This patient has a very strange pattern with diffuse streaky uptake within muscles. This patient actually had polymyositis. The patient on the right had multiple metastases to skeletal muscle. And I don't know that you would know this specifically other than the fact that there are a lot of lymph nodes in this patient as well. This patient presented with severe muscle pain. It was a young male with severe muscle pain. They suspected that this was a perineoplastic myositis, got a PET scan to look for a primary site of involvement. He had increased uptake in his stomach, and this was a gastric lymphoma. The polymyositis usually resolves, perineoplastic myositis usually resolves nicely with treatment and recovers quickly. This is the follow-up scan. He has diffuse uptake in his bones because he is treated with GCSF or erythropoietin, but you'll notice that the muscles have decreased in size and the metabolic activity has resolved. Inflammatory lesions within the GI tract can be difficult to identify if there is uptake within those structures normally. So there is often some uptake in the mediastinum, in the esophagus. If it is fairly intense, it can signify an inflammatory process or potentially a neoplastic process. This is a patient who is on metformin, and one of the ways that metformin works in lowering glucose is by causing secretion or excretion of glucose into the GI tract, and that is the case here. We try to suppress that by taking patients off of their metformin for 2 days prior to the procedure, but it's sort of a trade-off because you would like the serum glucose to be, less than about 150 ideally. I generally will go ahead, and if the glucose is elevated, I will go ahead with a PET scan up to maybe a glucose of 250 or so, but your sensitivity is going to be reduced above that. You can still try to do the PET scan, but sometimes it's difficult. This is a patient who was a leukemic patient who was treated with chemotherapy, developed severe abdominal pain, and you can see that the distal duodenum, the ligament of Trice, and the proximal jejunum show wall thickening and increased metabolic activity. This is a patient with typhlitis following chemotherapy. This is another patient who had increased uptake within the rectum as well as wall thickening of the rectum. This patient, this was an inflammatory process. Obviously, if you're looking for colon cancer, sometimes it's difficult to distinguish between the two. This is a patient who also had a history of prior inflammatory bowel disease. If you'll notice on the CT, there is subserosal fat, which usually indicates that there has been some sort of prior inflammatory bowel disease. In this case, the mucosa, the mucosal surface, shows increased metabolic activity indicative of a current inflammatory component. This is a patient who had acute diverticulitis, and you can see that there is increased mesenteric attenuation, a small focus here of enhancement, which corresponds to the diverticulum and surrounding bowel wall thickening. I think my pointer just died. Maybe need another battery. I'll try to point with the mouse here, although it's kind of hard to see. Anyway, so this is diverticulitis. This is a patient who was previously treated with radiation for rectal cancer and has this focus of increased uptake with a small area of air within it, and this is a fistula. FDG PET is incredibly sensitive for fistulas, even if they cannot be demonstrated by other mechanisms. I don't know what I'm doing wrong here. This is a patient who has a bacterial peritonitis, and you can see increased uptake, fluid collections throughout the peritoneal cavity. This should be distinguished from this pattern, which shows, which is a case of peritoneal carcinomatosis with omental caking. When you see this sort of intense uptake involving the, can you put another battery in this? Thank you. So when you see this intense density within the omentum, you're not usually dealing with an infectious process, but rather a tumor involvement. But you can see all of this activity deposited within the mesentery. And notice the posterior peritoneal surface in the pelvis. So this is tumor, not infection. Acute cholecystitis does show increased uptake on PET. Generally, mechanisms to diagnose obstructive cholecystitis are not a problem, but when you have gallbladder wall thickening without stones, that could represent an acalculous cholecystitis, and FDG PET is very sensitive for that. You can see this diffuse uptake in a thickened gallbladder. This is another patient who had breast cancer and was being evaluated for metastatic disease, which she did not have, but her gallbladder was very abnormal, with areas of increased uptake and also areas of sort of fat within the gallbladder wall. This is a case of xanthogranulomatous cholecystitis, which is a chronic inflammatory condition. She said she had sort of off and on symptoms for years, but she had her gallbladder removed as a consequence of this scan, and the diagnosis was confirmed. Xanthogranulomatous pyelonephritis is also another entity that can be identified on PET or by CT. Generally, you will have sort of the cystic collection, sort of chronic. You can see fat sometimes within this, as you did within the gallbladder. Generally, there's a large calcified stone within the kidney, but not always. And very often they have a chronic inflammatory nodal mass as well. This would be very difficult to distinguish from this entity, which is actually chronic renal tuberculosis, where you have cystic changes, calcifications, and areas of increased uptake. This is another case, a different case of renal tuberculosis. You see the changes within the kidney. You also see activity within the adrenal glands, bilaterally, within a lung nodule, and within mediastinal lymph nodes. This keeps dying. Do you have more batteries? I need a bigger pointer on this person. Okay, that's better. Thank you. This is a patient who had a renal transplant and who had acute pyelonephritis of the kidney. There was a PET scan performed for another reason, and you can see that there's sort of a striated areas of increased uptake. It might be hard to distinguish that from normal calyces, but if you'll notice, the areas of uptake correspond to regions of decreased enhancement on CT. So this patient had proven pyelonephritis. This is a scan that was performed in a patient who had recent placement of a metallic intrauterine contraceptive device and had pelvic pain, and she had diffuse increased uptake within the uterus, which was inflammatory and is actually fairly common after placement of an IUD. And on a follow-up scan that was performed, this activity had decreased and now looked normal. So that's an inflammatory disease. It is common to see a focal area of increased uptake within the prostate on a PET scan. You would like to say that this is prostate cancer 100%, but the fact is that it is prostate cancer less than 10% of the time. It is more typically an inflammatory process. Prostate cancer, poorly differentiated prostate cancer can be hot on FDG PET, but most prostate cancers show no uptake on FDG. If you see it within the peripheral zone, I think that's more suggestive of prostate cancer. in any event, the patients need to be evaluated clinically for the possibility of prostate cancer or infection, and it's worth noting in your report. So patients who present with either fever of unknown origin or more specifically with bacteria in their bloodstream, and this patient had methicillin-sensitive Staph aureus bacteremia, and so they knew there was an infection somewhere. They didn't know where or what the extent was. And this FDG PET scan in this patient was very helpful. There were multiple hypermetabolic lesions within the lungs, most of them peripheral, consistent with septic emboli. But in addition to that, you see subfascial areas of increased metabolic activity within multiple sites. So necrotizing fasciitis with staph. Staph is a facultative anaerobe, and it can grow without being anaerobic and may not be gas producing. So it's very easy to miss early necrotizing fasciitis, especially with staph, before it develops gas. And so this is a patient who had multiple muscle groups that were involved. This is important to know what the extent of disease is, because these patients can progress to a compartment syndrome and need to be followed closely. This is a patient with a gluteal decubitus ulcer, which extends to the bone, but it did not clearly involve the bone. This is another patient with a similar decubitus ulcer. In this case, you get sclerosis of the bone, irregularity of the cortex, and increased uptake in the bone, suggesting there's an associated osteomyelitis. This is a patient who had a maxillary resection due to head and neck cancer with a vascularized fibular graft. There was actually a wound draining internally into the mouth, suggesting infection, and the question was whether there was osteomyelitis, and there's diffuse increased uptake within this graft and around it, consistent with infection. The graft had to be removed. This is a patient with increased uptake within the L5-S1 disc space with an associated hypermetabolic soft tissue mass. This appearance is typical for discitis, osteomyelitis, for which PET-CT is quite sensitive, and based on the pattern, quite specific. So it's very helpful. This is a patient who had an osteomyelitis of the proximal tibia. You can see the signal changes here on MR. This is with contrast showing this lesion, and it was intensely hypermetabolic on FDG PET. This is a patient who had a pelvic reconstruction due to an acetabular, comminuted acetabular fracture. This was the post-op image showing, you have the surgical clips here. A follow-up image that was performed routinely was initially read as normal, but there were actually some funny little air connections here. I don't know whether you can see those well, which suggests that there may be more of a problem. The wound had not healed well, occasionally was draining. This is the PET scan that was performed to evaluate for possible infection, and it was much more extensive than what it was thought to be. There's a lot of air, intense activity within the soft tissues, in the muscles, and the bone, also activity within the joint space. And if you look at the femoral head here, you can see that it is, there's a destructive process. So this was extensive infection following reconstruction of the acetabulum with osteomyelitis. This patient had L4 or L5 posterior fixation rod. The skin over the rod chronically kind of reddened and occasionally draining. They went in and removed the hardware, and this was a scan that was performed later, approximately 3 weeks later, showing there was an abscess within the soft tissues, a fluid collection with uptake around it, as well as you can see where these screws were within the vertebral body. They're all hot. There was infection going into all the skin tracts. This is another patient with bacteremia. They had also had spinal hardware, which actually this looked pretty good. There was a mid-foot osteomyelitis, and there was this unsuspected uptake in the lower thoracic spine, sort of centered at facet joints, with a mass that appeared to extend into the epidural space. When you see this, you've got to have an MRI, and it confirmed that there was an epidural abscess in this patient. This is a patient with bacteremia and pain in the face. There was fluid within the mastoid sinus, and an FDG PET scan showed intense uptake within this region. Also going into the temporal bone here, you can see that this looks a little bit demineralized, and this was thought to be an osteomyelitis associated with this. He had a subsequent resection of his temporal bone, and osteomyelitis was confirmed. So I showed some of this with prior neuroimaging, but I'll show this again because it's a different group. But paraneoplastic CNS manifestations and mimics of brain tumor can occur with encephalitis, subacute stroke, and ictal seizures. This is an example of a patient who had a left temporal lobe, herpes encephalitis. The initial scans show increased uptake within the active areas of encephalitis. Subsequently, those areas of the brain become hypometabolic. This is a patient with HIV who developed acute neurologic symptoms and had multiple ring-enhancing lesions on CT, whereas it could be many things with an acute presentation and immunocompromised. The differential was either a primary CNS lymphoma versus toxoplasmosis. Toxoplasmosis, however, is typically low in metabolic activity. Sometimes also tuberculomas can be low in metabolic activity in the brain. In this case, there was increased activity in these ring-enhancing areas. This was primary CNS lymphoma by biopsy. This is a patient with limbic encephalitis. There is increased uptake in the hippocampus. You can see here on MR there was some enhancement within that area, and the activity will extend. You can see the hippocampus here on the left compared to the right side with increased uptake. This is a patient with anti-NMDR encephalitis, and the entire hippocampus is involved. We can recognize the hippocampus here medially, but you know, the hippocampus extends posteriorly as well, and this is a nice example of the extension of the entire hippocampus posteriorly with increased uptake, anti-NMDAR. So this is an autoimmune encephalitis. This patient, I'm sorry, that was also a limbic encephalitis. This is an anti-NMDAR encephalitis with multiple areas of increased activity within the brain, as well as a decrease in uptake within the posterior brain. When you see this pattern, it's fairly typical for anti-NMDAR encephalitis. So it's autoimmune mediated, but this large area of decreased activity, I mean, the other possibility, could this be a Lewy body dementia? You would not expect to see these sort of other areas of increased activity. Surprisingly, in this patient, the MRI was practically normal. This is a patient with prion disease, Hocke-Creutzfeldt disease, with multiple areas of increased and decreased activity on FDG PET, sort of corresponding to the appearance on MR, on diffusion-weighted imaging. This is a patient who presented to the emergency room with a stroke. On physical exam, they found a vulvar carcinoma that was quite large, and her workup focused primarily on her stroke initially. This is the non-contrast CT, which shows hypoattenuation, and then the contrast CT shows a lack of perfusion to this area. Her MRI shows edema on T2, and then your diffusion-weighted imaging shows characteristics of an acute stroke. 2 weeks later, she had a FDG PET scan to deal with the vulvar carcinoma, and on that study, which we did with intravenous contrast for the CT, you can see diffuse increased activity within that brain. That's usually due to a reperfusion inflammatory response, and this pattern here, which is pseudolaminar necrosis, which is also typical of a subacute stroke. So there are a lot of things that can mimic infection. This is a patient who was actively seizing but sedated at the time of the FDG PET scan, and you can see this diffuse increased activity during the ictal phase of seizure. This is a patient who had acute sinusitis with increased activity and fluid, but also notice the thickness of the maxillary sinus wall here compared to this side. So this is hyperostosis due to chronic sinusitis as well. In this patient, there was symmetric activity in the lateral pharyngeal recesses. There was uptake in the base of tongue tonsillar tissue as well as lymph nodes. All of this is inflammatory. This is a patient with an odontogenic abscess involving the mandible. Thank you.
Thank you, Professor Dr. Catherine. Now, Dr. Gabriel Fine, Professor of Radiology and Imaging Science at the University of Utah. Dr. Fine has a broad and active interest in many invasive treatments and interventions. He has been an invited speaker and moderator at international conferences and has multiple applications and abstracts. Dr. Fine has received several honors recognizing his medical and research contributions. The title of the presentation of Dr. Gabriel, Theranostics and Future Updates. Let's start.
Thank you so much. It's really an honor to be here and to be here in Alexandria with all of you. And I know that there's been some mention of molecular imaging and therapeutics, and we're going to do a brief overview to really try to give you guys a sense of what's happening now on the therapy side in this area. If I can move my slides forward. This is just a disclosure that I have. This is what we're going to try to cover: history, what Theranostics is, and a couple of the FDA-approved theranostic agents that are being used quite frequently now in our practice, specifically Lutathera or lutetium-177 dotatate and Pluvicto or lutetium-177 PSMA 617. A little bit about our practice and some future utilization. This was a mentor of mine who unfortunately passed away, but he really introduced me to Theranostics very, very early on before I went to medical school. Another mentor happens to be sitting over to my left in Dr. Morton, and I just wanted to take a brief moment to honor him. So what we're moving towards now in medicine is what people call precision medicine or personalized medicine, medical treatment customized to the individual patient. And Theranostics is really just that. It's an approach that allows selection of the best treatment based on confirmation that that tumor will accumulate and retain the therapeutic agent that you aim to use. It was initially termed in 1998 by John Funkhauser. That term had no G in it. You can see Theranostic. And then Suresh Srivastava at Brookhaven National Laboratory decided to use the word Theragnostic. We kind of use both. Most people, I'd say, use the Theranostic term now. But really, this concept's been around longer than I've been alive. And now that I'm middle-aged, that's a pretty long time. So back in 1938, radioiodine was discovered, and that was used for thyroid cancer and hyperthyroidism, which for all intents and purposes was our first theranostic agent. So the strategy, you image with the diagnostic agent first. It allows selection of your patient appropriate for the therapeutic application. That could be PET, SPECT, optical imaging, MRI. In some cases, we'll use dosimetric imaging for therapy planning, and you can also use this for assessment of therapeutic response. So this is the concept. You have a combination of your therapeutic and diagnostic specific targeting moiety. Let's see, I'm not sure if I can, I'll use this here to try and, just look on the image here. So we've got our combination of either therapeutic or diagnostic imaging agents. So we can have for therapy beta or alpha emitter, or for diagnostics beta or gamma. We have this linker, this linking molecule, a binding molecule, then our target. So this diagram is just sort of showing that, and you can interchange the diagnostic agent with the therapeutic. The therapeutic payload can be a variety of things: chemotherapy, radiotherapy, a combination or a direct link, or within targeting nanoparticle. Many of you guys probably are familiar with radioactive decay, but we take advantage of this, both for imaging with gamma and radioactive decay either to beta or alpha particles for the therapeutic treatment. These are all theranostic pairs that have been in use. We're only going to really touch upon a couple. Some of you guys may be familiar with what we talked about with radioactive iodine, but there's really a large range, and this area is expanding rapidly. So these are just some, and we're going to see more in the future. And this kind of just references the field. People are publishing on it very, very dramatically now. And this is the first one that we're really going to try and go into in a little bit more depth. Peptide receptor radionuclide therapy, or lutetium-177 dotatate. It's chelated to peptides, specifically a somatostatin analog. It's used to treat gastroenteropancreatic neuroendocrine tumors, as well as other neuroendocrine tumors at this point, too. Lutetium emits high-energy electrons, which are beta, so that's our therapeutic, and gamma, which is the imaging component. You guys have heard about targeting of somatostatin receptor earlier today, and this peptide targets somatostatin receptor, particularly somatostatin receptor type 2. What is somatostatin? It's a peptide hormone. It halts neuroendocrine tumor hormone production and neuroendocrine tumor cell division. The original somatostatin that binds to the somatostatin receptor has a very short half-life, so these analogs that have been created, such as octreotide and lemreotide, allow us to do more because they last longer, about 90 minutes. This particular study is called NETTER-1. This was in the New England Journal of Medicine, which is one of the most well-cited journals in the United States. And it was a phase 3 clinical trial assessing lutetium-177 dotatate for mid-gut neuroendocrine tumors. This concept is from the company where you inject this treatment. So this Lutathera gets injected intravenously. It binds to somatostatin type 2 receptors, overexpressed on the neuroendocrine tumors, is internalized, and then emits your beta radiation to ultimately kill the cell. For the therapy, what they assessed was lutetium-177 dotatate plus octreotide versus octreotide alone. They gave the patients 4 administrations every 8 weeks, plus octreotide versus that octreotide alone. For eligibility criteria, they had to make sure patients were greater than 18. They had metastatic or locally advanced mid-gut neuroendocrine tumors that were inoperable and had progressed during treatment. They had to have a decent Karnofsky score. The tumors were well differentiated, and somatostatin receptors had to be shown to be present in all target lesions. For exclusion criteria, for all intents and purposes, they had to have decent renal function, decent bone marrow function, and decent liver function. The treatment with octreotide greater than 30 milligrams had to be within 12 weeks before randomization, and they couldn't have had PRT at any time prior to randomization, and any surgery, liver-directed therapy, or chemotherapy within 12 weeks. And this is a Kaplan-Meier curve, survival curves. Typically in the Kaplan-Meier curves, the higher up on that curve, so the line being closer to the top, is better. And usually in a lot of the studies you'll see some separation, but this was really profound. I mean, you can really see a dramatic difference in progression-free survival between these. And in overall survival, it also appeared to be heading that direction too. And this is what they found: a 79% reduced risk for progression-free survival, and increased overall survival of about a year. The patient's quality of life was dramatically improved, and the safety profile is quite good. Progression-free survival with octreotide, which remember was standard of care, is 8.4 months versus 28 to 29 months with Lutathera. So patients suffering from neuroendocrine tumors, this treatment has been profound for them. It's been really a game changer. So the FDA decided to approve it. Novartis bought this for quite a bit of money, and we've treated many patients who are still alive after having received this many years ago now. So this is our treatment regimen. They'll get Lutathera 4 times every 8 weeks. Between that, they can still get their long-acting octreotide, and after those four treatments, then they're usually done with Lutathera, though people are exploring additional retreatments now. The administration typically starts with an antiemetic, so we give something because they can often have nausea. We give an amino acid solution to really protect their kidneys, and then we infuse the Lutathera for them each time. Oftentimes the patients are nauseated, as I mentioned. They can have other things such as hyperglycemia, myelosuppression. A small percentage can develop leukemia, so that is a possibility. Anemia, thrombocytopenia, neutropenia are all also possibilities, and there are occasional patients that have to be delayed. Radiation release is pretty good, so they really have a pretty limited emitted exposure. They do excrete a lot of radiation in the urine, and they typically have to do routine radiation safety precautions if they go home. We want them to urinate frequently. Once this radiation has gotten to their GU system, we want it out of them. We don't want it irradiating anything other than the tumor, and we try to limit that as much as possible. This is an example of a patient that would be a good candidate for Lutathera, and they actually were treated and did quite well. So this is a gallium-68 dotatate MIP on the left, where you see multiple sites of uptake, which are all metastases. On the right-hand side, you see a MIP of an FDG PET-CT. As long as it's projecting well, hopefully you can tell that the intensity of uptake is profoundly more in the net spot, or the gallium-68 dotatate PET-CT. On the right-hand part of the screen, you can see the same thing of an axial PET-CT of the net spot, or gallium-68 dotatate PET-CT, versus the FDG PET-CT, and the uptake is just profound on the net spot. That's suggestive that the somatostatin receptor is very highly expressed in these tumors, and they're likely to respond better to the treatment. Another example of a very similar sort of thing, where you just see such intense uptake on that gallium-68 dotatate PET-CT with much less uptake on the